Hello, I'm Dr. Derek Lee. It's my pleasure to welcome Dr. Suken Shah, who is Professor and Vice Chair of the Department of Orthopedic Surgery and Division Chief at the Spinal Scoliosis Center at the Morris Children's Hospital in Delaware. He's an innovator, researcher, and key opinion leader in the field of spinal deformity surgery with over 200 research publications. He is a professor of orthopedic surgery and pediatrics at Sidney Kimmel Medical College of Thomas Jefferson University and serves on the boards of directors of the Setting Scoliosis Straight Foundation and the Scoliosis Research Society. I have to say that I've thoroughly enjoyed following your work on the management of AIS in terms of your treatment parameters, your research, your non-surgical and surgical decision-making rationale. Now, whether it's observation, bracing, or surgery, selective thoracic fusion, or VBT, I'd love to hear your perspective and your thoughts on that.
Well, thanks, Derek. It's a pleasure to be here. Appreciate what you do for patients and families by trying to distill the accurate information and providing a really balanced view of things. So appreciate that. Appreciate you having me on your show. So I thought we'd start out with kind of a talk that I've done and you've seen that goes over a lot in a relatively short period of time, but hopefully can be approachable to you folks starting out on this journey. We know things are quite complicated in this space, and moreover, things are changing. Where do you get good information? Where do you get reliable? What's your reliable source? So hopefully this will direct most people to getting that information. Idiopathic scoliosis, unfortunately, is still considered idiopathic, meaning we don't really know the cause. We think that the pathoetiology, or how it happens, is anterior overgrowth. That means the front of the spine grows a little bit too fast versus the back of the spine. And because the thoracic spine is already rotated about 3 degrees, it tends to tip that seesaw in that direction. There's a vicious cycle that happens with asymmetric growth, further rotation, further curvature. And that's why it affects adolescents, because they're in a very quick growth spurt during their prepubertal years. To mechanical engineers, this is very interesting with the concept of column failure and buckling and crankshaft rotation. Numerous investigators have named phenomenons of vertebral wedging and rotation, but this is what the spine looks like on a 3D CT scan, where you can look, the red arrows are pointing at that lordosis that occurs. That's really the unstable part of the spine that tends to rotate the most, which is why you see curves most commonly in this location of the spine. So when an anxious family who's been told they have scoliosis either by school screening or their pediatrician comes to see us, what they really want to know is whether that curve is going to progress. Their sort of default thought is that their child is going to need a complicated operation, not be able to do sports, and really undergo a lot of painful treatment. And the problem is that our relatively unsophisticated ways to determine progression are somewhat primitive. They're getting better, but most of the time we function as fortune tellers, trying to predict what will happen in the future with relatively little information. But things are changing. For instance, in this article, we pointed out that we can tell from the first X-ray sometimes how a curve is going to develop, not from the coronal plane X-ray or what you're used to seeing in the curve, but from the sideways or lateral X-ray, where the sagittal malalignment is really the integral part of the development of AIS, very much what Bob Dixon and Stuart Weinstein have written about earlier. And maybe we can use this to address early stage treatment. And the Montreal group has taken this one step further to look at the 3D morphometric parameters of the apical vertebra and apex of the curve. So looking at disc wedging, vertebral body wedging, rotation, something they call slenderness of the vertebra, very tall but not very wide. There are 6 criteria, and they continue to innovate, and not only very predictive on the first one, but even more accurate prediction on the second X-ray to something of about 90% accuracy. So we're involved in a multi-center trial with them, looking at patients to maturity, and then hopefully work backwards to see what the most important criteria are at the first radiograph. But right now, these are criteria endorsed by the Scoliosis Research Society. the indications for management of AIS are kind of broken down into these three buckets. We observe patients with small curves with serial exams and x-rays. Unfortunately, now we have low dose x-ray, we have morphometric analysis, we have a good clinical exam to determine when small curves get bigger. Non-operative treatment centers around bracing, primarily curves between 25 and 45 degrees when you look at their Cobb angle. And some people add scoliosis-specific exercise regimens to this group. And then operative treatment are for bigger curves, curves that are greater than 45 degrees. Most of the time we would quote 50 degrees. And here you have posterior or anterior treatments. Now, why is 50 degrees that magic number? It's really because curves that are 50 degrees or more, even when you're done growing, tend to progress into adulthood. And the concept here, or the patient recommendation here, is have surgery when you're young, because the recovery process is quicker, complication rates are lower, our ability to correct curves is greater, and hopefully we can keep that treatment localized to a small segment of the spine, rather than what most adult deformity surgeons have to do is a very long fusion, sometimes to the pelvis. This is really the landmark article proving that bracing works. We were fortunate to be part of the 22 centers that were involved in contributing patients to Stu Weinstein's study. Very excellent methodology. Started out first with a randomization arm and then a selection arm. And the primary outcome of avoiding surgery was achieved in patients who were braced. In fact, the study had to be terminated early because the Data Safety Monitoring Board determined that it was not ethical to continue to randomize patients to no brace. So here are the results. If you look at observation, those patients with no brace, it was pretty much 50-50 that you were going to have surgery or the curve was going to progress to 50 degrees. If you were braced, you had almost a 75% chance of avoiding surgery. And this is very compelling evidence that bracing works. The other key finding is that there's a dose-dependent response to bracing. The more you wear the brace, the better you are at achieving avoidance of surgery. And so if you see here, if you were in the group that wore the brace full-time, you avoided surgery 90% of the time. Even if you wore the brace part-time, you avoided surgery 70% of the time. So I use this to really counsel patients that, look, you've got to have buy-in to this treatment. I know that it's unpleasant wearing that brace to school, and I know that it's unpleasant to discuss this with your friends, but look at the later effect of possibly avoiding surgery is huge. There are many different braces available now, and we can't get into the specifics. Some braces are better for some curve types, some braces are better for some patients. And the rigid braces seem to stand the test of time for efficacy. We really can't endorse the spine core brace because most of the studies don't show an efficacy like we just demonstrated with the BrAIST trial. And the two braces included in the BrAIST trial were the Boston brace and the Wilmington brace. Well, who do we brace? You can't really brace people who are skeletally mature and expect anything to happen with the curve long term. And you can't expect to brace people with very large curves and expect much to happen. Now, the exception is juvenile and infantile patients. Bracing is still a hugely important treatment modality, even if their curves are 60 degrees. So we're really just talking about adolescents here, and those indications of curves between 25 and 40 degrees seem to be the best patients. But sometimes you can buy time, and anyone who's skeletally mature really should have this discussion. What does it mean to be skeletally mature? Is it your age? Is it your premenarchal status? Is it your Risser sign? Well, it could be all of those, but what's most important is the Sanders scale and the Sanders staging method, because this has been proven to be the most accurate method to look at remaining skeletal growth. And that's a hand x-ray. And you may be wondering, well, what does the hand have to do with the spine? It really goes back to the ossification pattern. Your fingers all the way down to your wrist, from the pinky to the thumb, we have these nomograms or tables to look at what's happening. So this is the key stage to identify, for instance, stage 3. That means this child is in peak growth velocity. And all of the growth plates in the fingertips are open. In fact, the little wafer epiphysis growth plate is wider than the metaphysis. That's a key feature, and it comes around like a cap. That's why we call it the curve acceleration phase, the cap, the capping. Orthopedic surgeons need kind of a easy way to remember things. So stage 3 is peak height velocity. That's when capping occurs. And then this is the table out of Jim Sanders' article where he looked at presenting Sanders stage, Cobb angle, and what is your likelihood to progress to need surgery. Very compelling. Again, everything in the white boxes tends to indicate 100% progression or very likely to progress. And everything in the gray box indicates that you're probably not going to progress, but bracing could change the natural history, right? So we brace everybody in the white boxes, definitely everybody on that border perhaps who wants to be proactive, but don't really need to brace anybody on the far right. The thing was, this was only based on 22 patients. Can you really hang your hat or treat real people with just that data? Well, we validated Jim's work with 160 something patients and found that the statistics were virtually identical. So Sanders staging works, it's very accurate. Presenting Cobb angle versus Sanders stage, these are sort of the progression potentials to expect. So with 20 current models of bracing, the most frequent brace is an underarm thoracolumbosacral orthosis, such as pictured here, with a compliance meter to really determine and educate and take that opportunity to counsel patients to wear the brace more. What about Schroth and other scoliosis-specific exercises? You need to see a certified therapist. There's some special equipment, and it seems to be hard to maintain this exercise regimen over time. But I've seen some amazing results with really compliant, dedicated, passionate patients and therapists that can achieve great things together in combination with bracing. So it's something to consider. And some studies, even this RCT, looking at Schroth versus bracing alone, there seemed to be a small effect with adding Schroth to bracing. And in this group, almost 80% of patients either were stable or had improved curve magnitude when combined with Schroth. So it's available, and it's something to consider as a part of the non-operative treatment regimen. But what happens when your curve progresses? What happens when the curve is large? Or what happens when some of those prognostic factors that I discussed earlier indicate a near 100% chance of progression? You might need surgery. And the traditional goals of surgery were to halt progression. Now we can correct the deformity with very sophisticated implants. We want to maintain spinal balance, and this isn't just getting straight in the frontal plane, but it's also restoring kyphosis in the lateral plane, restoring some of that rib rotation in the axial plane. So it's a three-dimensional problem. You need a three-dimensional solution. But it's all about preserving motion now. We don't want to make people stiff. We want this surgery to be durable over time so that they perhaps don't need another surgery even when they're an older adult. And obviously, we want to be safe about the surgery, prevent reoperation, complications such as infection and neurologic deficit. So there's a lot to consider. Classification is important to try to keep the fusion as small as possible or the treatment as small as possible. And King Mo stood the test of time for 30 years. But then we realized in a three-dimensional problem, you need to approach a more comprehensive classification system. So Larry Lenke and the harm study group sat down for several years trying to develop a better curve classification system that was comprehensive, at least two-dimensional, treatment-based, reliable, and something people could really use and use to communicate. So this was borne out now in the Lenke classification, first published in 2000, where we have 6 curve types and several things to consider about whether it's thoracic, lumbar, or double major. Also, what the lumbar spine is doing, is it very off-center, and how do we incorporate that into the treatment? And then also the kyphosis. This is the second dimension. There are some people we want to do anterior surgery on versus posterior surgery on, depending on their kyphosis in their thoracic spine. So this algorithm of looking at the x-rays, classifying the curve, being treatment-based, and then being used for communication and research or talking to other treatment providers is very important. But then also looking at your report card and how do we validate our outcomes in surgery. This has been a huge step forward. So let's take this patient with a double major curve. That means it's a Lenke 3CN. She required a fusion of both curves from T4 to L4. So the assumptions with this classification system are always fuse the largest curve, then look to see whether those compensatory curves are structural. So structural curves are rigid ones that aren't flexible, or ones that are kyphotic, which could become a problem if you don't fuse them later. This classification system has a strong bias towards selective thoracic fusion or selective lumbar fusion. trying to fuse as little as possible, rather than the typical old way, everybody gets T4 to L4. Selecting fusion levels is always seemingly a mystery to our trainees. It shouldn't be. Sometimes it seems to be an artisan craft. We would love to have AI standardize this someday in the future, but most of us will use the center-sacral line passing through the middle of the sacrum, extending that up, and where does that touch the vertebra? Where does that intersect the middle of that vertebra? So there's some initials here. EV means end vertebra from the cob. Neutral vertebra means the one that's less rotated than all the rest. And the stable vertebra is the one that's bisected by that center sacral line. The lowest instrumented vertebra is where your fixation is going to end. Usually, the fixation is going to be somewhere around the last touched neutral or stable vertebra. Sometimes they're all the same, but sometimes they're different. So in thoracic curves, we like to start with looking at the LIV at the stable vertebra. This is always a very safe choice. But in our motion preserving mindset, we are able to go up one and save some motion segments in the Lenke A curves, the Lenke B curves, and even the Lenke C curves. So this is very curve specific, and this is where the nuances for what different surgeons do come into play. But the center sacral line, last touch vertebra, is a pretty solid criteria. So in this C-type curve, we've stopped at the stable vertebra with a very nice result. But here we've used the screws to specifically derotate the lumbar curve to get better correction and move that modifier from a C to a B, and perhaps someday even an A, as that lumbar spine modulates and comes over to midline. So the selecting the last touch vertebra in this article from JBJS was very reliable, even at 5-year follow-up. And then when you look at the side, there's also this concept of the sagittal stable vertebra. This is also something very important to consider. After you've chosen your level on the coronal film, look at the lateral and say, okay, I'm not making a mistake by stopping too short based on the patient's lordosis or kyphosis on the side view. So let's kind of use a real example to break this down. This is a 13-year-old female. At first presentation, shows up with a curve bigger than 50 degrees. We can't really observe this because she's got growth remaining. We could brace her, but the end effect is going to be the same. This curve's still going to be pretty big, maybe even bigger, and we may have missed an opportunity to do a little bit more selective treatment rather than have to fuse both curves. Because as you know, when left alone, this curve is going to get bigger, and so is the lumbar curve. So we recommended surgery. By the time we kind of get on the schedule, get our ducks in the row, the curve gets a little bit bigger. But this is what we have to work with our preoperative study. So right before surgery, the x-rays are the ones that matter in selecting our levels and planning our treatment. So here we say that the triradiate cartilage, which is also a marker of peak height velocity, is closed. So big growth spurt over, but still has significant remaining growth. She has just had her period. She's in 7th grade. She's interested in sports. What's the best treatment for her? I think with this trunk shift and the curve already being over 65 degrees and not really being in the sweet spot of growth, we recommended posterior spinal fusion. So the bending films tell us which curves are structural, which curves need to be treated. Always treat the largest curve and leave the compensatory curves alone. So here we've got a main thoracic curve that's big, a lumbar curve that's very flexible, a sagittal alignment that shows significant lordosis and hypokyphosis, and the bending x-rays showing that the lumbar spine is pretty flexible. So that's a Lenke 1A minus. That means she's got less than 10 degrees of kyphosis in the thoracic spine. We've got to build in some kyphosis if we want to be three-dimensional about our treatment plan. The MRI was obtained because she's presented with a large curve. There were no solid neurologic findings, and I'm not advocating getting MRI on every single idiopathic patient that walks in the door. But because the curve was big and progressed, we got one. This tells you what's happening at the apex. This tells you a lot about disc health and the spinal cord, and fortunately, everything was normal. Her clinical photos indicate the trunk shift, the angle of trunk rotation, her motion, and what we need to do in the sagittal plane to bring that lordotic apex out. Fortunately, with low-dose stereoradiography, we can really look at the spine in 3 dimensions, analyze the curve pre-op, We can get surface renderings of the spine, and this is impressive where you really see the true lordosis when you derotate each segment of the spine and take a look at the spine in 3 dimensions. Now we develop our treatment plan specifically for sagittal plane reconstruction and axial plane. The coronal plane is always going to get straight, but we want to be very intentional about a 3-dimensional correction. So now we look at the levels. What's the top? What's the bottom? Are we going to do some osteotomies? How are we going to contour our rods? What are we going to do in surgery to make this spine better in 3 dimensions? And so if we match these up, we've got our curve classification. There's moderate remaining growth. We've got to treat that apical lordosis. We're going to go from T4 because the right shoulder's up, down to L2 because that was the last touched. We're going to use a specific implant system with uniplanar screws and a high implant density to get that apex around and elevated out of the chest. So this is an intraoperative picture where we've done facetectomies and Ponte Osteotomies to make the spine more flexible. And already you see the spine has floated up dorsally. There's almost a spontaneous appearance of kyphosis because we've released a tension band. This is really impressive and also offloads the implants. When you can kind of do this before the implants are even in, you know that you're going to achieve a nice correction. Well, why do we do this routinely? Because virtually all patients need kyphosis in this scenario. If we lengthen the posterior column, we get better coronal correction, axial correction, and sagittal correction, better restoration of kyphosis, which has a lot of effects on the neck, on the lumbar spine, on pulmonary function long-term. If you make the spine more flexible, you can do a safer correction and a better correction in 3D. Now, differential rod contouring can get a little bit complicated. And in addition to picking levels, sometimes for our trainees, rod contouring becomes a mystery. I come back from the back table with 2 rods that are ready to go. And until later in the year, they don't appreciate what's actually happening with rod contouring until you give them the rod and ask them to bend it. Uniplanar screws have been great in this type of surgery because we can fine tune the sagittal correction, but we've got a solid way to derotate that apex, which is very rotated. So usually the concave rod for me is very bent, very kyphotic. The convex rod is relatively flat. I've got a short video here just showing you the difference in that rod contour. So these are 2 rods for the same patient. One's going to go in on the left side, which is the concave, and the other is going to go in on the right side, which is convex, and bend over that rib hump. So the steps are pre-op planning, establish goals, mobilize the spine in surgery, use your implants to correct the curve, and then do a post-operative assessment, x-rays, clinical photos, and most importantly, patient-reported outcomes. How is the patient and their parents perceiving this surgery as an effect on their quality of life and satisfaction with treatment? At the end, this is what you would like to see with a completely derotated spine corrected safely, minimal blood loss, no neurologic deficit. Our post-op films show good standing balance in both planes, but the 3D is where it's at. So here, pre-op, we had all that apical lordosis and rotation. Post-op, excellent coronal, sagittal, and axial plane realignment with restoration of kyphosis and virtually very little rotation at the apex left. And so if you put them side by side, pre-op and post-op, this is the kind of correction posterior spinal fusion with instrumentation in 2022 can achieve. And this is the standard to which we should aspire with all of our treatment because this patient is going to have an excellent long-term result as proven in the literature with 10 and 20-year retrospective and prospective follow-up studies showing a very low rate of complications. So this concept of selective thoracic fusion is very important for patients who want to preserve motion. If you've got a curve that looks like it's 2 curves, you should really think hard about whether that patient's applicable for selective thoracic fusion. And we continue to push the boundaries for leaving lumbar motion and leaving lumbar curves alone to preserve motion. Lenke and Bridwell talked about this in the 90s. There are some ratios which we consider to be safe criteria for choosing this operation. This is a girl with a 60-degree thoracic curve, 40-degree lumbar curve, very deviated. Does she want to continue enjoying the motion of the lumbar spine? Of course she does. She wants to continue dancing and playing sports well into her middle age. And this is a 1C curve. And so we did a selective thoracic fusion, stopped at L1, preserved almost all of those motion segments, and really derotated the lumbar curve. And looking even at 3D, a very nice result long-term with excellent post-op appearance. Now, if you leave a significant lumbar curve alone, you're going to have to tolerate a little bit of waist asymmetry. And I tell the patients post-op that this is what, pre-op, this is what you want to expect post-op. But most people are so happy with the residual motion, they don't care about this little bit of waistline asymmetry that they can probably hide very effectively. So these are the criteria. You need the lumbar curve to be a little bit bigger and more rotated. Sorry, you need the thoracic curve to be a little bit bigger and more rotated than the lumbar curve. And initially, they may look a little bit to the left, that they tend to come over very nicely if you've done your pre-op planning very well. And a key thing that I learned from Peter Newton and we continue to sort of propagate is this counter rotation. So pick your stable vertebra, pick your neutral vertebra and rotate that lowest instrumented vertebra the other direction to get that lumbar curve to come around. It's almost like wringing out a towel. And also the sagittal plane, restoring kyphosis helps this harmoniously get better too. But I think what a lot of people want to know about now is, can we avoid doing a fusion? What's sort of missing in this whole equation? We've got the 3D spinal growth figured out. We have a better knowledge of what's happening to the discs. We've got some animal models to look at what happens when we try and stop growth on one side of the spine. We have an accurate prediction of who's going to progress. So why don't we put this all together and get better at trying to figure out whose curve is going to get worse. So with the goal in mind of avoiding fusion, scoliosis correction without fusion has been the holy grail for people like me and other members of the Scoliosis Research Society. We want to harness the growth of the spine to correct the scoliosis, not make it worse. Like mechanical and biological, perhaps, treatments in the future for this. So we went back to the anterior approach, which sort of fell out of favor in the 2000 era. Correct anterior growth inhibition, restore sagittal alignment, and get spontaneous derotation of the spine. And that's where vertebral body tethering has taken off after years of doing anterior surgery in a fusion model, looking at this concept again with maybe perhaps a refreshing eyes and better implants. So this is when you put screws in to the front of the spine on the convex side, squish that down and try to get the other side to grow faster than the convex side. And so over time, with growth remaining, you can get correction of that curve. Very much like the analogy made of braces on your teeth and growth modulation in the knees for bow legs, we can use growth on the slow side to get correction over time. So this is what the device looks like outside the body on a model. Screws with a flexible cord or a tether or a cable applied to the convexity of the curve. I think this should be done in a minimally invasive fashion thoracoscopically to preserve the chest wall and pulmonary function and get very rapid recovery with minimally invasive surgery. I also think you need to have continued growth of the spine to get the best results over time. And we're also learning that the initial correction during implantation is very important to perhaps prevent tether breakage in the future. So these are intraoperative photos inside a patient's chest, thoracoscopically with very small incisions. We take down the pleura, identify the discs, the bodies, put a staple in to anchor the screw, then put the screw in through that hole. Very important to put the screws in parallel to the disc, avoiding the disc, avoiding extensive protrusion on the other side of the vertebral body. Now installing the tether, the cord, and compressing those screws together to get the spine corrected on the table and tensioning that cord so it creates an effective growth on the other side and inhibits growth on this side. And this is the sort of final tether picture. And these are the incisions we use. We're now down to 2 smaller incisions because we can kind of go up above and below the ribs, and then just a small port in the front with the camera, and then that becomes where the chest tube is put in for about a day. So this is more or less a pretty ideal candidate. The curve is flexible. It's not too big. There's a lot of growth remaining. Sanders 3A, 3B seems to be the sweet spot for this technology. Here are the vertebral body screws in the initial correction, first standing x-ray. You tend to lose a little bit in the first standing x-ray because now gravity is acting on the patient. And with each subsequent x-ray at 3, 6, and 12 months, we should see slow correction. We get correction up to about 18 months, and then you're sort of set. Then it's a race against time to skeletal maturity versus tether breakage. We think that eventually most, if not all of these tethers are going to break, but if the spine's straight and the patient's done growing, the long-term result should be very nice. So these who to do it on continues to evolve, but I think most people would agree that we need to look at young people with growth remaining with flexible curves, not much bigger than 60 degrees. Now, if you have too much growth left or you've over-tensioned the tether, you tend to get overcorrection. I think we've got a little bit better handle on that. And depending on what you think about reoperation, the surgery for this is fairly simple: to cut the cord and let the curve kind of go back to where it wants to, or replace the cord with a little bit of slack to allow a more neutral position spine. Sounds great, but where's the data? How do we know this is safe for patients? How do we know it's effective? There is a humanitarian device exemption available now in the United States for this technology. It's very well done in Canada as well. It seems to be very popular in Europe, and Asia is following suit. So this is really taking off. But when you look at the hype innovation curve, you really want to be responsible about what you're doing to patients. So Peter Newton's a very honest reporter, was one of the first to develop an animal model for tethering and one of the first to do a significant amount of patients clinically. His results after 2 years are pretty sobering and caused a lot of people to take pause at whether we should be continuing to do this technology, because 50% of the patients required a reoperation. And when you look at a 41% revision rate, 47% broken tethers, a quarter of the patients had a posterior spinal fusion subsequently or scheduled to have one, and x-rays that look like this, we really got to wonder whether we should be doing it. But he was doing very large curves, and the technology hadn't evolved to the point where we really knew that intraoperative curve correction was important. So we can learn from this experience. In a subsequent report, compared to posterior spinal fusion, 9 revisions in the tether cohort, and 6 of them are converted to spinal fusion. No revisions in the spinal fusion cohort. 50% of patients had evidence of broken tethers. But there were several patients, obviously, in the tether cohort that could avoid fusion, whereas all the patients in the fusion cohort had a fusion. There were no difference between the patient-reported outcomes. So again, if you are willing to accept a higher rate of reoperation, tethering still seems to be a viable option. However, if you require the gold standard, a low reoperation rate, a reliable operation, you're very conservative, fusion is the way to go, according to that study. The other thing we're learning now is the complication rate is dropping as we refine our criteria, as we get better at patient selection. Avoid the big curves. Avoid patients that are too young or too old. Let's get into a sweet spot where this operation can be reliable. Now the complication rate seems much more approachable. 21% revision rate with tether revision and conversion to fusion. In Samdami's IDE study, a 12% revision rate, but this is only at 2-year follow-up. And the Canadian experience with Montreal and Vancouver, Feroz Mianji, Stéphane Parent, again, a complication rate hovering around 20%. And as we get better, is that going to go lower? Or is that the follow-up increases, are we going to see more tether breakage and a higher revision rate? That's really where this inflection point may go one way or the other. And that's why it's very important to participate in long-term prospective studies when asked to by your surgeon, so that we can collect this data and really report back to our surgeon community and our patients about this treatment option. So we used to say, look for it someday. Obviously, it's here now, and it's something that should really be entertained and studied. So it's not all about the widgets and the technology. I think surgeons get caught up in that, but we have all of this. We got to consider safety and avoid allogenic transfusion and avoid neurologic deficit and avoid radiation to our patients. We also have to look at quality and value. One of the main things we've been able to do with reduction in length of stay after spine surgery is better pain control without opioids. It's amazing. Our patients are awake, they're alert, they want to cooperate with physical therapy and leave the hospital in 2 days. The complication rate has gone down, the reoperation has gone down for fusion at least, as well as the cost as we continue to innovate with these other kind of non-widget, maybe less sexy, important treatment applications. Well, thanks very much, Derek, and I hope I covered the areas that are really interesting to our patients and families.
Oh, absolutely, Dr. Shah. I really appreciate the rationale, how you select patients for tethering versus VBT. And it's kind of interesting to see, as you highlighted, how VBT is coming on, because innately most people just don't want to be fused. They prefer to have motion restored, et cetera, et cetera. And while selective thoracic fusion, if we look at just thoracic curves or curves that those are the primary curves, the trend has been to move towards thoracic tethering, and now the trend is kind of moving back towards selective thoracic fusion, just because of, as you highlighted, reduced complications, better long-term outcomes, less revision rates, et cetera. Now, one of the questions I had is, there's always innovation in technology. And we've heard, of course, that there's going to be perhaps stronger tethers coming along. Do you think that's going to play a significant role in expanding parameters for tethering once again, because they are narrowing, as you know?
I'm not sure if a stronger tether is going to expand our indications for treating larger curves. I think a stronger tether is probably going to reduce the breakage rate. And but you don't want to go too strong, right? Because then you're approaching the biomechanics of a rod, and the whole thing about preserving motion and disc health sort of goes away. So there's, again, a movement towards stronger tether, but we still have to keep the motion and the disc health at top of mind if we want this to be true to its mission. And so the interesting thing is this sort of pendulum swing to tethering and back to selective thoracic fusion, which is a great operation. And I think it's because motion in the thoracic spine, first of all, doesn't seem clinically important to most people, is very hard to quantify and capture and prove that it's any better with than a fusion. So for instance, in the latest JBJS study where Josh Pays and colleagues at the Philly Shrine looked at gait lab analysis, motion analysis after tethering versus fusion, found very little difference in the thoracic spine except thoracic rotation. Well, the only people that do significant thoracic rotation are dancers and certain performers. But thoracic rotation really isn't part of the everyday lexicon of people walking around playing recreational sports. It's all about lumbar motion that's most important. And in the future, lumbar tethers versus lumbar fusion probably going to show a much bigger difference. And a more distal lumbar fusion is obviously already been shown to affect motion and disc health. That's why people are congregating around the lumbar spine as the real pot of gold, so to speak, to preserve motion.
Now, some surgeons if we go back to tethering, are moving towards doing double tethers or two tethers to try and reinforce the area. I guess along the lines you mentioned in terms of, well, maybe a stronger tether might not be the end all and be all because it's restricting movement even more. Yeah. Do you yourself use just single tethers, or do you also do double tethers?
Yeah, for the thoracic spine, typically single tether, because first of all, the vertebral bodies are smaller. The rib cage does restrain motion a little bit, and choosing the right patient is real important in hopefully trying to avoid tether breakage. The lumbar spine, though, the tethers are more prone to breakage because there's so much motion there. And because lumbar vertebral bodies are bigger, it just seemed natural to want to put 2 screws in and 2 tethers. So then you get back into this question of, are 2 tethers too stiff? Are they restricting motion enough that there's going to be degenerative disc disease? Because we keep addressing the mechanical aspect of tether, but we also have to address the biological aspect of disc health and growth plate and all the things that are so important at motion preservation. So if you keep trying to constrain something so much that biologically it dies, then we're still like back into taking a step backwards. So there's so much here to unpack from a biologic standpoint and growth standpoint that we're at the infancy of this era, which is really exciting part, but also why this whole thing causes trepidation to people who are conservative in the area.
Sure. Well, with respect to disc health, if you look at, let's say, worst case scenario for a tether is that it does cause disc degeneration. It might cause, for instance, autofusion just because there's lack of movement. How does that relate to if you're just doing a regular thoracic fusion, for instance, or a lumbar fusion, where the discs aren't going to impact it anyway? Is it that? I guess what I'm asking is that if your options are tethering or fusion, with respect to the disc, does it really matter if there's disc degeneration or autofusion? If you fuse, if fusion is your other alternative?
Yeah, well, that's an interesting question, right? And I think the reason in patients chosen well, the reason the fusion works for, say, cervical degenerative disease or lumbar degenerative disease is because you're eliminating motion in a painful segment. But if we're trying to preserve motion in the first place, we need that disc to be healthy. And there's no motion in a fusion. So if those discs autofuse, say, from a 16-year-old by the time they're 21, there's no motion to make that area painful. But because there is residual motion with the tether, if the disc degenerates, will that become painful in the future is something that we're sort of slightly worried about, but have yet to see. I think that so far, you've got a small number of patients who are 10 years out, very small. You've got a larger number of patients that are 5 years out. You've got a tremendous number of patients that are 1 and 2 years out. These are the folks we have to follow for 10 years and 20 years and ask them how they're doing with regard to back pain and axial complaints in the future. Now, if they have residual motion and they have no pain, okay, this thing worked. But if we're just creating a population of thoracic back pain for the future, we're going to have a treatment for that. Right.
And it seems that one of the major parameters between choosing selective thoracic fusion and thoracic tether is basically flexibility, basically. For yourself, how far does the VBT candidate have to flex in order for you to consider that? Lower than 30 degrees, lower than 25?
Yeah, 30 degrees is a great number. I also, it's a clinical thing. They don't understand the degree measurement. It's all for them. It's about how much motion they can create clinically. Can they touch their toes? Do they come close to their ankles? What about lateral bending? Lateral bending is a nice thing to illustrate a big difference, right? In lateral bending with someone who's been fused versus tether. And so I like to show them during the exam, this is what we're looking at, and this seems to be preserved in tether patients, and this seems to be sort of sacrificed. So lateral bending is a big difference. Forward bending seems to be very little difference. Thoracic extension seems to be different, but thoracic extension is almost a non-physiologic thing for most people. So when you break it down, I think they have a better understanding, but if they have already made their mind up before the visit, I don't think there's much I can do to change their mind. I want to support their decision if it's appropriate by giving them all the facts and let them choose. So for me, this is a real kind of shared decision making, right? I mean, naturally, we could steer people the way we want by certain things we say, which, you know, are very important to patients. But I like to be pretty balanced. And if someone truly is a candidate for procedure A or procedure B or both procedures, then I tell them that. And then armed with that knowledge and perhaps what they've heard before or willing to look at later, they come back with a decision that I can live with.
Absolutely. The shared decision making, I think, is key to everything. As you know, once you have a really well-informed patient, it does take the discussion to the next level in terms of trying to look at viable options.
Yeah.
Question I have is that, well, if a patient comes into you and they have like a 60-degree thoracic curve, even a 50, and they can't bend down to 30, but they still want the surgery. Let's say they can bend down to 35 or high 30s. What do you do in that circumstances? And you know, with the internet, people are looking at options, and they're looking at is disc release an option for you because it increases flexibility? What's your perspective on all that?
Well, I think disc release is going to accelerate the whole issue of disc degeneration that we spoke of. When you look at animal models, and all you got to do is put a needle in a disc to accelerate disc degeneration and create disc degeneration for all these studies with chymopapine and disc replacement and so forth. Why would I ever want to slice it open and have all that stuff leak out? So I think for rigid stiff curves, I'm going to fuse anyway. Disc release has been awesome. And thoracoscopically, it's a very elegant technique to make a very stiff curve more flexible, provided I'm going to do a fusion posteriorly. But I don't apply that in combination with tethering. And so flexion for me isn't necessarily a criteria for whether someone might be eligible for fusion versus tether, because I think motion is very unique to certain patients because of their collagen makeup, their flexibility inherently, effort, how we measure it. It's all over the place. Stiff patients are going to be stiff after surgery, regardless of what you do to them. Flexible patients will continue to be very flexible after surgery, regardless of what you do with them. And so I look more at radiographs, curve flexibility, clinical exam and bender, and growth remaining as the sort of put it all together in the pot algorithm.
Okay. Just a couple of questions. It seems that with the relatively high tether breakage rate, maybe around 20%, I know some surgeons are kind of playing with the concept of doing a single level fusion at the apex as they tether. Do you have any thoughts on that approach?
That's interesting. And so, I mean, it's a combination. And the other hybrid is selective thoracic fusion with a lumbar tether for a double curve pattern, you know. Again, you can sort of do innovation, but if you don't collect data and you don't report it, we're never going to learn anything from that. And so if someone's doing something really innovative, I want to hear about it at a meeting, but I also want to hear about what happened to those patients afterwards. And so we got to be really careful about doing things to people and not reporting it, because then someone else is going to do the same thing that didn't work, and they're just going to be sort of propagating a myth or bad clinical judgment. But when you're reporting your results, it's very important to disseminate that information. And that dissemination of information in the current age is so quick. I think a lot of people could avoid harm if we're responsible about the science too.
Now, Will Burke told me that you have an interesting methodology in terms of control of pain and recovery. Would you like to touch on that a little bit? It's pretty fascinating, yeah, sure, because that is a huge concern with recovery and managing pain with patients.
I know. Well, it's a little bit different with tether versus fusion because the nature of the operation is a little bit different. So I'll take tethering first. By the way, we've eliminated IV narcotics from all of our patients, period. There's no PCA, and the vast majority of patients get no IV opioids their entire hospitalization. So we've gone to oral medications to control pain and a length of stay less than 2.5 days. And that's for fusion and for tether. So how do we do that? First of all, we set up patient expectations that this is what's going to happen, this is how we're going to do it, and this is our data. Now, I would say that 20 years ago, people wanted to experience no pain. Opioids were the best way to get there. And the length of stay was 5, 6, 7 days, because the first 3 days were all about getting the patient off PCA and out of bed. But when you get the patient out of bed the day of surgery and don't use any IV narcotics, they're going to have a much better hospitalization experience. So with tether, we do an intercostal nerve block with a catheter connected to a pain ball that disseminates that long-acting anesthetic over the 2 days. That pain ball gets removed before they go home, and they have a great experience because of the intercostal nerve block along the side of the chest where the portals are. We put them on oral opioids for a couple of days, but where we're really have excelled and where our real interest is in the non-opioid adjunct medications. So we use anti-inflammatory medications, IV and oral. We use a clonidine patch to help them sleep better. And this really novel study that was spearheaded by one of our anesthesiologists was when we were using PCAs, he was looking at the nighttime button pushes as a quality of sleep indicator. Because if you're asleep and you're having good pain control, you're not going to press the button, right? You're not even awake. So the people that had a clonidine patch and had good pain control weren't pressing the button at night. The other thing we were using very early was IV Toradol. Orthopedic surgeons had a fear of Toradol from trauma literature and old spine literature, but it does not inhibit fusion. It does not cause, it's a very safe medication when used in a short burst and then, taken off. But it really moves the needle in terms of pain control so that you're not using opioids. And then Neurontin or gabapentin. Gabapentin is an agonist of the pain receptor. And so it competes with the pain receptor for opioids. And if it blocks that pain receptor, the opioids are much more effective. And so patients that receive gabapentin use less opioids, but have the same pain control. And then when you go to the fusion side, because the incision is longer and there's more muscle retraction, they get more muscle spasms. Valium is very important to control the muscle spasms. And a long-acting liposomal bupivacaine is very effective. So we inject this medicine right into the erector spinae muscle as a block before we do our closure. And over the next 2 to 3 days, that anesthetic is leaking out of the liposome and causing the incisional pain to be dramatically better, I think. Several of us are studying this medication in comparison to our older methods and are very happy with the results. So if you're now approaching a family in 2022 who wants to avoid opioids because of our crisis and epidemic and danger of conversion, this is a great matchup of patient expectations and desires with our desire to control pain better without opioids. And so they go home on a week's worth, which is by state law, the current mandate, and they're not even using all the medication they give them. So we did a study in JBJS several years ago where we showed our peers that we're discharging our patients with way too much medication. They're not even using half of it. And what happens to the medication that's laying around in the bathroom medicine cabinet long term? Well, other people are going to use it. It might fall into the wrong hands. It's just dangerous and unnecessary. So it's a multifaceted approach, multimodal pain control, and it's been a great differentiator for our spine program.
And it sounds like you really make the effort to educate the patients to let them know what exactly is going to happen. That's excellent. Because they must panic a little bit. What, I'm going home in 2.5 days? Right?
Yeah, well, it's a
after
big
major
change,
surgery.
right? Yeah, and we've had several go home the next day. And you know how competitive people are. When they start hearing that, oh, well, what's the soonest a patient went home? These people that are overachievers in every facet of life, and they want to go home soon too. And home is where recovery should actually happen, right? And once we've deemed it safe that they can go home because they're ambulating and they're getting good pain control orally, if the family's on board, they go home and they have a great experience. Now, we also maintain very close contact with them when they're at home through digital means that's very secure, through an app that they can communicate with, telemedicine for our patients who come in from out of town so they don't have to travel back and forth. And it's been a great satisfier.
If it do, what happens to the chest tube in terms of you just leave it in for 2.5 days? And it's
no, we really work hard to get that chest tube out on post-op day 1 so that they can go home either late that night or early the next day. The chest tube for the VBT patients seems to be the kind of what holds them back from discharge the most, I would say. So the sooner we can get the chest tube out, that means they're going home the next day most of the time. But that's all, it's all about drainage, right? So if the drainage is very low, we can pull it out early. And when you do a very meticulous dissection and the procedure is very quick, and you're not making a lot of holes in the bone and there's not a lot of bleeding, then the drainage is going to be very low right off the bat.
Right, because you're producing less fluid to begin with. One last follow-up, since we're down this path, for lumbar tethers, especially if you go deep into lumbar spinal and you have to kind of either retract or separate the psoas, there seems to be more complications with respect to nerve pain down the leg or hot and cold feet, depending on how do you guys address that particular issue of complication?
Yeah, well, that happened to our adult colleagues who were doing a lot of lateral inner body fusions, right?
Right.
The psoas is a big, beefy muscle. There are nerves running through it that are very hard to see. And so retraction causes a temporary neuropraxia and pain. Most evidenced by weakness with leg flexion, going upstairs, getting into a car, and that thigh pain. So nerve monitoring is really important. And you can do that regionally, peripherally by our neuromonitoring colleagues that we normally use during surgery, and then looking locally. So you can put a probe near the psoas into the muscle and slowly dilate and keep stimulating those dilators to make sure you're not pulling on the nerve. And as soon as you are, and you start to see some EMG activity, maybe you better change the placement. What we like to do is go anterior to the psoas as much as possible, or posterior to the psoas as much as possible to avoid retraction. And so it's very important looking at an MRI to see the psoas anatomy, which is unique in very patients. Where does the iliac vein bifurcate? Where does the psoas lie on top of each of those vertebral bodies? And trying to figure out the best pathway with least retraction. But nerve stimulation in that local area is very important.
Dr. Suken Shah, thanks so much for your time. Thanks for your presentation. It was spot on. I know you'd produce a very well-designed presentation, and you did. Thank you so much for your time.
Sure.
Really appreciate you participating in this interview series.
No, I appreciate it, Derek. It was a pleasure. And thanks again for everything you're doing.
Thanks very much.